welcome to all. Hello, and a very warm welcome to all the members of audience to this fourth webinar, Comprehensive Surgical and Physiotherapy Intervention in Pediatric Scoliosis, under GAPIO Physiotherapy International Lecture Series. GAPIO is Global Association of Physicians of Indian Origin. It's a non-profitable organization established in 2011. Padma Vibhushan Dr. Pratap C. Reddy, Hospital Group, the founder president of GAPIO, with a vision improving healthcare worldwide, with the aim to bring healthcare professionals of Indian origin in the world on one platform. Through these webinars, our endeavor is to bring the latest advances in the field to fraternity globally. Pediatric physiotherapy as a branch has been established so well that today we have lined up a sequence of prominent champions from the medical and physiotherapy field to discuss an important concern in pediatric population: comprehensive surgical and physiotherapy intervention in pediatric scoliosis. I'm sure this webinar will ignite our thought process. We may have many questions. Participants are requested to put their questions in the chat box, and it will be addressed in the end in Q&A session. Now, without taking much time, we have with us Dr. Urmila Kamath, Head Department of Rehabilitation by Jerabai Wadia Hospital for Children, Mumbai, to introduce pediatric physiotherapy journey. With her rich experience of 40 years dealing with neonates and children, she is recipient of C.P. Nair Oration Award 2005 with many publications to her credit, shaping pediatric physiotherapy with evidence base. Over to you, Dr. Urmila.
Thank you, Seema. Thank you for that lovely introduction. Well, it's really been a pleasure at the outset. Let me thank Dr. Seema and the entire team of GAPIO for allowing me to participate in this beautiful, beautiful seminar today. It's been challenging. Talking about pediatric physiotherapy, friends, it's been evolving, and it has evolved a long way. For me, it's a long journey of 40 years now. I started working in pediatrics in Paediatric hospital, and it was just a few children who were referred for, simple things like passive mobilizations or strengthenings and everything, calipers and everything. The era changed, and I have been fortunate to witness the changes that are happening in pediatric therapy, from being referred to as please do passive exercises to being now a self-referral, which is a huge change in this. But gaining this recognition and becoming an integral part of every specialty with every professional, be it endocrinology, neonatology, or orthopedics, has been the great change for us. Well, physiotherapy pediatric practices, what are the change per se? There are just 6 pointers which I would like to say here because time is of greatest concern. So from being passive, it is now a complete active therapy. Instead of it is an integral part, but only mobilizations and strengthening, we now focus on function, on the ICF model. Helping children to rise above their disorders, their disabilities, and going into functional retrainings for making them the best of possible outcomes in the society. So I think, and for this you use multimodal approaches. There are various treatments, there are various therapies, there are various things. What is important is what is the best for your child. And the aqua therapy gaining momentum. We now have the land as well as the water to give our children a better outcome again. Well, another thing is advances. How do I call it in terms of age also? We started at adolescence, moved to childhood, and now where are we? We are into neonatology, where we are the first, even in that early NICUs, preterms, 32 weeks, 28 weekers, where we are in high-risk OPD as an integral part of our whole team. And that is why we have now moved in pediatric therapy through early detection from rehabilitation to habilitation, a preventive angle. But my dears, all this in a nutshell. But all this has been possible because we have evolved as a team. Working, you cannot say that I am the professional who will do it. We are as a team working with all our professional colleagues, all our associates, all our other professional colleagues like orthopedic, surgeries, neurologists, everybody to name it. And that is what we have evolved as. So first and foremost, in a nutshell, this is what I would say the journey of pediatric physiotherapy has been. But today, let us first think of one of the very challenging topics. And I would like to congratulate Dr. Seema for selecting such an interesting topic and giving us what a platform to understand from our esteemed speakers today what are the realities of treating pediatric scoliosis. What is the scope, but what are the limitations also? Can we achieve what we really want to? Keeping those ground realities, I think I hand it over again to Dr. Seema. Please go ahead with the.
Thank you so much, Dr. Urmila, for just summarizing in such a short time.
Thank you.
I believe we all can really say that pediatric physiotherapy is such a big field, but she has just highlighted all the points that how this journey took place. So now, despite many advances in understanding scoliosis and its categories, much of its prevalence is yet to be predicted in Indian population. I hope my colleagues will voice the same. It can be neurohormonal condition rooted with genetic predispositions. We as physiotherapists can retain the postural memory and much more for these scoliotic patients. Now, without taking much time, I invite my colleague, Dr. Elizabeth Joy, Head Department of Physiotherapy, Apollo Hospitals, Bangalore, to moderate the session. Over to you, Dr. Elizabeth.
Thank you, Dr. Seema. Good evening, all. It is my great pleasure to introduce our guest speaker for today's webinar, Dr. Ramani Narasimhan. Dr. Narasimhan is a highly respected pediatric orthopedic surgeon with over 23 years of experience at Indraprastha Hospital in New Delhi. He has a special interest in the management of disorders of the pediatric hip, spine, and has been recognized with numerous awards for his contribution to the field. Dr. Narasimhan has presented and published extensively on pediatric orthopedic surgery and serves as a Vice President of the Pediatric Orthopedic Foundation. Today, Dr. Narasimhan will be taking a presentation on surgical management in pediatric scoliosis. Please join me in giving a warm welcome to Dr. Narasimhan to our webinar today. Welcome, sir.
Thank you very much, Dr. Elizabeth, for such kind words. It's a pleasure to be a part of this forum. And thank you, Dr. Seema, to have invited me to this, very interesting get together. And let me start without too much of, not wasting time. Just a second. Let me, yes. All right. So what I'm going to basically do is
make it full screen.
Yeah. Yes. So what I'm basically going to do is take you through to how we approach a case of scoliosis and what all investigations and what are the things that we are looking for in terms of the clinical examination, in terms of the X-rays, and then plan out the management. Sometimes we need to do further imaging to understand what exactly is there and then plan out the management. Sometimes you don't necessarily have to operate, but there are certain things that you have to do. So starting off, this is a case example. This is a 10-year-old boy who has been brought to the office with incidental spinal asymmetry. Noticed by the parents, he is asymptomatic. Other history is non-contributory. So what do you see? So what we are basically seeing is a normal height. We see appropriate maturity. There is a full left trapezius. There is a mild trunk shift. There is a left clear space in flank crease. There is a prominent lower right back. And there is a level pelvis. And physical examination, you observe, especially if the child is wearing the underclothes, skin, posture, symmetry, range of motion, flexibility, Adams forward bending. you always look at the feet. We will come to that a bit later, but we are looking at any increased in cavus, which gives you an idea that there might be an upper motor neuron lesion. Then you have to do a neural examination. It includes gait. And now scoliometer is something which is good for picking out cases and referring, but I generally personally don't use a scoliometer because it gives a wrong sense of the rotations, trunk rotation, but it's important for the referral person to pick up scoliosis sometimes and send it across to the right personnel. And especially if there is 7 degrees or more of the rotation, you generally refer the case. Now, when you test for ROM, the Adams forward bend test is very important, because when the child bends forward, and then there is a trunk shift, and this particular hump that you actually observe right from the head end and also from the side gives you an idea that what exactly is happening to the spine, because whenever there is a lateral curvature of the spine, there has to be rotation of the vertebra, especially in the thoracic region, which would make the rib hump very prominent. So you notice this because of the hump that you see. Now, in a general observation, you see the height, the weight, the BMI, the pain, and the age of onset is important. Relation to the growth curve is important. Sexual development, menarche is important. The history is important. Development and nutrition, general health. And you have to basically observe with your mind open, because there could be many causes for scoliosis. We will come to that again. You have to observe for any skin cafe au lait spots, which can be seen in neurofibromatosis. There could be a kind of a occult signs of spinal dysraphism, which you should not miss. Now, this is the kind of sinus or tuft of hair if you see at the back of the back, and that can give you an idea that there is something spinal dysraphism going on, which could be the cause for scoliosis. Now, this is what I was talking about. The upper extremity, of course, you look for, depending upon if there is a neurological problem in the upper extremity, but the lower extremity, especially a cavus foot, is important to pick, because that gives you an idea about an upper motor neuron, which could be prevalent. Always look at the feet when there is a spinal deformity, and look at the spine when there is a foot deformity. So what are the various types of scoliosis? Idiopathic, when the cause is not known. It could be infantile, it could be juvenile, it could be adolescent. Infantile, depending upon what age it starts. Juvenile, again, 3 to 10 years, and adolescent later. It could be an early onset, less than 5 years, late onset. Congenital, it could be a scoliosis, kyphosis, lordosis, but we are talking about scoliosis today. There could be a neuromuscular cause. It could be myopathic, spastic versus hypotonic. There could be various syndromes, and we don't want to go into details. But then there could be an obvious scoliosis, like you see on the left, a 2-year-old with progressive, painful left scoliosis. But there could be a 13-year-old girl who is actually looking very balanced, but she actually has a double curve. Sometimes these double curves are difficult to pick up, but if somebody is doing a thorough examination and properly taking a history, you tend to come across it, and then you approach it in an appropriate way. And then these kind of curves, a younger child with a curve who is an immature child, a curve which is any curve which is closer to 30 degrees is likely to progress. So you need to plan out the management and intervene as early as possible after proper counseling of the family. Then these are the curves where you can see the various kinds of curves, but what is one thing which you have in common is all these curves are 50-degree curves. So what you have to understand is the curves which are in different regions of the spine can present in a different way, but they may all be of the same magnitude. Now, this is a congenital scoliosis. You see, this is a hemivertebra, and this is a congenital bar. So a combination of a hemivertebra on one side and a congenital bar on the opposite side is probably the most deadly combination, totally, which is properly a kind of a soil for a very fast progressive scoliotic curve. So, but it's not very common to have a combination of two. So, but any of these in isolation is something which you have to be very, very careful about, and you have to pick it up early. And you have to know that whenever there is a congenital scoliosis, we have to check for kidneys, because there could be a 20% chance or 25% chance the kidneys could be involved, spinal cord could be involved, 20 to 40%, and heart can be abnormal in 10%. Now, these are the defects of segmentation. These are the defects of formation. So these two things, formation, which includes the hemivertebra, and segmentation is the unsegmental bar. Now, this is just to tell you that this is an unsegmental bar that you see. This is a hemivertebra that you see. Now, here is another girl, a painful scoliosis in a 6-year-old. Be concerned about a child with a painful spine, because that is an indication for an MRI, and you can pick out a syrinx, a diastematomylia, a tethered cord, and be very concerned about the child with a very stiff spine. So neurological examination, I'm not going into all these details, but what is important to examine is a deep tendon reflex and abdominal reflex, because these can give you the subtle signs as to whether there is a neurological involvement or not. And gait, of course, is important. And these are this is a very extensive Lenke's classification, no question of going there, but it's sometimes King's classification for idiopathic adolescent scoliosis is less extensive but reliable, and sometimes I'm very comfortable using these. Growth, of course, what is important to understand is postnatal spine growth velocity is highest. In the first year continues until the age of 5 years and increases again after the age of 10 years. Now, in physical examination, general height, weight, Tanner stage maturity, deformities, general health, nutrition. You have to look at the child standing, cervical spine flexibility, trunk shape, balance, limb length, discrepancy, if any, because of the trunk deformity, skin markings, pubertal development, then Adams forward bend test, which can look for the amount of problems that one has. Then if the child is prone, then you can check for the spinal flexibility, because that is how you take those bending curves before planning out any surgery. Neurological examination, of course, is important. Now, this is an 11-year-old girl with a 29-degree scoliosis. Now, these are the questions that should come into one's mind. Where is she in a growth curve? Is her triradiates open? Has she reached her peak growth velocity? Has she started periods? What is the risk of this curve progressing to 50 degrees? Because that is the time when you start thinking about surgery, especially in lumbar curves, 40 degrees in thoracic curves. Now, sometimes you use this Sauergrein's method of growth remaining, where you are actually looking at this olecranon epiphysis and the amount of fusion that has occurred here. That gives you an idea about the amount of growth remaining, because these are prognostic factors which you need to discuss with the family, take decisions regarding the intervention that you have to do. Now, these, if the triradiates are closed, if the child is already has had a Minarch, then the chances are about 5.75% of percent risk of any progression. But in this particular case, the growth curve was just starting, the triradiates were open, she had not reached her growth velocity, she had not started her period. So the risk of progression was 75%. So that's how you have to be, you have to time your intervention depending upon how important it is to start early. Now, reserve sign is something which you see on the pelvic crest, and that gives you a sign of maturity, but it doesn't even start until after peak height velocity. So you have to be very, you have to wait along with the history that you are taking, the X-rays that you are doing, and the skeletal maturity and the sexual maturity that the child has achieved. Now, the lung development is also important. Generally, by 5 to 8 years, the lung is all matured. So sometimes you have to take decisions before that, especially in terms of congenital scoliosis. So that is where this information is important. So here is a case. So that was a kind of a background that I wanted to give you. Here is a case, 11-month-old boy. Parents felt that there was a swelling over the left lower back. The child not bothered. Noticed when he started standing with support. Birth history uneventful. The X-ray spine. This was the picture, and there was some suspicion of a hemivertebra here. So there was a left L3 hemivertebra. Then there was co-ops angle of 32 degrees. MRI, nose cord anomaly. ultrasounds of abdomen and pelvis was no abnormality of kidney. Parents were counseled. Swelling had increased after 6 months. You can see this fullness in the lumbar spine. Cobb's angle was 38 degrees now. So we have documented progression, right? So you can see that the curve has increased here. The operating planning to stop the progression of the curve. That is the primary objective here. The plan, prophylactic convex growth arrest. We'll talk about this. Hemiepiphysiodesis, as we call it, both anterior and posterior. So both anterior and posterior was done in the same sitting. First anterior, when we went on the convex side of the curve, we identified the vertebra, one vertebra above, one vertebra below. We made sure that we have fused the spine anteriorly on the convex side. Then we went posteriorly, because once we have fused there, then we go posteriorly. The convex side is all fused. We don't have to go on the convex side, concave side. And usually the concave side doesn't have too much of growth to contribute. But if it has, then it is a bonus. In this particular case, we got lucky. So this is all per-operative. This thing, immediate post-op, this was the X-ray. 6 weeks after, we used a brace. Now, follow-up after 15 months, this was the X-ray. The clinical snap was this. The child was, the upper and lower parts of the spine were growing normally. The middle part, which was contributing to the deformity, had been arrested. But after 3 years, surprisingly, lo and behold, we had a 25-degree curve, which was good because there was some amount of growth going on the concave side, which helped us. But by and large, you don't generally see this. But we got lucky here, but this kid was doing well. After 5 years, the parents were happy, did not progress, and convex growth arrest, optimum form of early prophylactic surgical management for patients with small progressive scoliosis due to failure of vertebral formation, where there is some growth potential on the concave side. Indications: less than 5 years of age, short curve due to fully segmented hemivertebra, correcting to less than 40 degrees with patient's supine. Contraindications: kyphosis. So any correction is welcome. And this is some supportive literature. I'm not going into details. And this is another case of an adolescent idiopathic scoliosis, 15-year-old girl, severe back deformity, progressed in last 5 years, menarche at 11 years, no other relevant history like backache, no proper treatment, pre-op Adams forward bending test. You can see the severity here. Then we marked out the vertebra, checked out, then we planned out, and we planned, there was a D4 to D11 right-sided 100-degree curve. So that was a huge curve, not relenting much on bending views. Pulmonary functions were okay. Pre-operative counseling done. Plan anterior thoracoscopic release, because that would, basically the deformity is in the anterior part, the bodies. So you have to release that part to get the necessary correction and make the spine more flexible for us to get the correction from the posterior side. So that's what we planned. In the first stage, we did this thoracoscopic release, which basically eases out the disc spaces between at the apex of the vertebra, and went behind. We obviously had the spinal cord monitoring, and we did this segmental instrumentation. And this was we got a post-op Cobb's angle of 52 degrees, because we are not really trying to straighten the spine. I mean, that is not the idea. The idea is to get the correction. Correction comes a third on the list. The first is the arrest of the curve, then the balance of the curve, then the correction. We'll come to that. Further, after 1 year, this was the situation. The curve held, and this girl was doing well. After 2 years, again, everything going fine. She finished her PhD, got married recently. I got a phone call about 5 years ago that whether she can have a child. So I was happy that she was doing well. She had not come to me. So sometimes that gives you a lot of, a kind of a boost that things are going well. But not every time you get a good result. Supporting literature again, I'm not going into details. Now, so there are certain management salient points. I'm concluding now. We look out for asymmetric muscle prominence, back in infants, and head trunk asymmetry in an older child. We look for occult signs of spinal dysraphism, nevus, dimple, sinus, tuft of hair. Cause, we have to check, we have to make sure that we have a cause in hand, because it gives you a proper way of, planning the management and giving the prognosis to the family. Then look for curve progression, which warrants some form of intervention. Generally, one may observe, brace, and operate, but generally this holds true in idiopathic curves. Role of orthosis, especially TLSO and CTLSO, is more in idiopathic, but in syndromic, it's you can only delay it. Even in congenital, sometimes you can use it delayed, but ultimately you need to operate. Any curve more than 40 degrees curve in thoracic area warrants surgical intervention. Surgery in order of decreasing priority addresses arrest of the curve, balance of head and trunk, and lastly focuses on correction. Infantile, juvenile idiopathic curves need correction and maintenance, but delay definitive fusion. Convex growth arrest is an important tool in selected children with progressive congenital scoliosis due to hemivertebra like we just saw. Hemivertebral excision and global fusion after correction using instrumentation is also effective, especially in L5-S1 region, especially in older children sometimes when there is not much growth left. Segmental instrumentation is the norm in present day and age. Spinal cord monitoring along with the wake-up test is mandatory in most scoliosis corrective surgeries. Detect early, treat early for best outcomes. Thank you very much. Hello. Hello.
Yeah, thank you, sir.
Was I audible?
Yeah, yes, sir.
Oh, yeah. All right. Thank you very much.
Yes, sir. Thank you, sir, for your enlightening presentation on the assessment and management of scoliosis. It was very informative.
Thank you.
I would like to welcome the guest or speaker for next session, Dr. Satyagi Sengupta. Dr. Sengupta is a physiotherapist and Deputy Director of Allied Health Specialty at KK Women and Children Hospital in Singapore. He holds a Master of Physical Therapy degree from Bombay University and a Doctor of Physical Therapy degree from the University of Michigan Flint. Dr. Sengupta's expertise and dedication to his field has earned him numerous awards and recognition throughout his career. We are thrilled to have him here today to share his knowledge on physiotherapy management in pediatric scoliosis. We are privileged to have such an accomplished and dedicated professional to share their knowledge and expertise with us. Please join me in welcoming Dr. Satyagi Sengupta to our webinar today. Welcome, sir.
Thank you very much. And thanks for giving me the opportunity to present. Scoliosis actually has been quite close to me for a long time, actually. So when I was studying in Calcutta, I think I was quite interested in scoliosis, and I used to work quite closely with some of our visiting surgeons who used to operate, and I used to go around with as a young student. So actually, scoliosis always fascinated me, and somehow I end up, when I joined KK, I had an opportunity to do develop the scoliosis service with our surgeons. So without saying much, let me go back to my presentation. I'll try and share my screen. Just give me a moment. Everybody can see my screen now?
Yes, sir, we can see.
Okay, so I think it's my pleasure to share my little knowledge in the physiotherapy management in scoliosis. But actually, to be very honest, physiotherapy cannot be isolated and be a part of management. Scoliosis is a team management. It includes the physician, the surgeon, the physio, and the orthotist, to be precise. So basically, I think as has been just discussed in terms of what is scoliosis. Scoliosis can be defined as a three-dimensional torsional deformity of the spine and trunk, because when we have a scoliosis in thoracic region, I think there is rotation of the vertebra and our trunk is also. And normally when scoliosis is confirmed, when a corpse angle is equal to above 10 degrees, and there is visible rotation in vertebra. So I think I will just repeat some of the things that, there's postural asymmetry, and then we need to look at this postural asymmetry for scoliosis, in terms of the head, shoulder, rib, waist shape, pelvis, rib cage, and prominences and leg length, whether it's true and apparent. I think scoliosis can be functional and structural. Specifically, it is important if you're thinking from physio, in terms of intervention. And I think, as it has been discussed, that the Adams test is done with a scoliometer. So we are looking at a prominence of the convex sign with the ATR above 5. And we also should look for the lateral deviation of spinous process. And sometimes when we look laterally, we also will be able to see disruption in the normal flexion curve when we look at the patient from a lateral aspect of the spine. Yeah, so that's also quite evident and what we look from structural and functional. So the functional scoliosis, normally the spine will come the ATRs, it will be coming as straight, whereas when the patient is standing, there can be a curve which gets corrected in forward bending, or sometimes when I think X-rays are taken, bending films are taken, I think the curve is not seen. So that's how we look out whether the scoliosis is structural and functional. So from the functional means there can be secondary or extra spinal causes. So we'll focus on the curve which are structural, where we need to we have to focus our interventions. So out of the structural curve, 20% is related to other medical conditions, neuromuscular, congenital. There can be quite a lot of other causes where we have structural curve, and around 75 to 80% are idiopathic curves. So I think this has been covered. So when we're looking at idiopathic curves, and normally they present during the rapid growth. So we have infantile, we have below 3 years, we have juvenile, 3 to 10 years, and we have adolescents, which is quite common, right? 10 to 18 years or earlier, depending on signs of puberty or whether they have menarche or some. And 80% of this actually presents during the adolescent growth spurt, right? And those scoliosis which are below 10 years and aggressive, they are also called early onset scoliosis. So I think etiology, quite there can be various reasons, and because it's called idiopathic, actually we don't know. But what we know is there is a torsional condition, so there is a bit of 3D alignment issue. And also there are some studies have shown that there are vertebral body growth disorders in idiopathic scoliosis, and that's why they have a term called relative anterospinal overgrowth of vertebra. All right, so these are important because some of these concepts are used when we are thinking of the conservative management of scoliosis. So I think has been covered already. I think skeletal growth is important. So we need to assess the child from height. We need to see the reserve. We need to see the Sanders stage. Depends on what we are looking at in terms of looking at the maturity and when is the menarche and what amount of growth is left, whether the curve will progress or not. So there's some things we need to look into, and where is the window of the time we have for the intervention to take place, specifically if it's idiopathic scoliosis. So this is just explains, the growth curve progression and when we should and how we should monitor. Specifically, pre-menarche, there is a growth curve, and post-menarche also there is a growth which slows down. So during this phase, we need to monitor idiopathic scoliosis quite closely. So the aim of treatment is to stop progression, improve aesthetics, improve pain, improve body image and acceptance of asymmetry, and improve quality of life, right? Because we're looking at idiopathic, predominantly girl, or aesthetics is very important, even if they are quite young and they may not understand, but when they really grow up, I think their body image has a big psychological impact on them. So what are the treatment options that we have? All right. So depending on when they show what the curve is, the option initially can be observation. But observation does not mean doing just, doing a scoliometric test. So observation means we need to take routine X-rays in a regular interval depending on where the growth is. So the X-ray one has to be taken depends on where the child is, at what portion of the, whether the growth, the child is during the stage of the growth. And normally, because these kids needs a lot of X-rays, can be for a few months to 6 monthly. So it is advisable if there's facility to take which is called the EOX X-ray, which is a low radiation X-ray, so that they are not, the children are not exposed to a lot of radiations, right? So this EOS is a different kind of X-ray, where the child is scanned, and also they have a facility of reformatting, so it can be used for surgical planning as well. So the next thing is what we call as physiotherapeutic scoliosis specific exercise. So there's a few types of things that we can do. So that's the other alternative. But basically all has to work in tandem. Then we have bracing, and then we have surgery. So this is the gamut of interventions that we have for children with scoliosis, specifically idiopathic scoliosis. So the care model is observation depending on the growth, what is the curve, how much is the Cobb's angle. So the kids can be observed, but they need to come and visit us regularly. Regular X-rays has to be taken. The measurements have to be done. Their growth has to be measured. So the next is we do specific physiotherapy intervention plus observation. And when the curve moves, I think normally when the Cobb's angle is beyond 20, around 25, I think the brace is recommended. Depending the growth. If the child does not have a lot of growth, I don't think brace is recommended, because even if the child progresses in Cobb's angle, the Cobb angle may not grow for us as big as for a surgical consideration. Right, so those kids may be managed with exercise and observation. So these are decisions that have to be taken depending on the Cobb's angle as well as the growth the child has left. So how they are growing. So we need to assess all those things and take a decision how we manage the patient. So basically, if you look at the treatment, depends, as I've just told, the maturation, size of the Cobb, and whether they have pain and other symptoms. So we can look at a traditional treatment model. So if you look at 5 to 10 degree, we do nothing. Even for 10 to 25, watch and wait and reevaluate. So if we take a functional treatment option, so we take monitor high risk, respond growth when it happens. Treat to reduce curve as they never have a surgical curve. So in this cohort of where they are 15 And before the brace is being recommended, so SRS recommends around 25 degree to start bracing. So these are the periods where we can do quite a bit of intervention in terms of the physiotherapy, so as to not only try to manage the progression, but also because the body alignment in the different planes can really be affected with very curve specific physiotherapy, and that improves their body image. And that's how we progress in terms of doing intervention with children with scoliosis. So when it comes to physiotherapy, all right, so there are a lot of therapy can be done. We can do exercise for our trunk, we can do core strengthening exercise, but basically what seems to be working is what is called physiotherapy scoliosis specific exercise are some of the concepts. One is the RIGO, the best one concept from Spain. Best practice is one concept from Germany, and ISST is Germany. So the first three primarily what we know as Scott's physio. So these are all evolved from Scott technique, which is a curve specific exercise program. And the other methods that are there, means I'm not aware of it in terms of the other methods that have been developed, but these are also a group of techniques. These are termed within the physiotherapeutic scoliosis specific exercise. I'll come back why they are called, because they have been found to be have evidence and really affect the outcome of the patients with scoliosis. So this has core principles. What do they affect? They basically, one is education. Next is active correction in 3D space. So that aspect is the therapy is very targeted, where there is active correction in 3D. Subsequently, we need to try and stabilize the corrected posture and transfer this stabilized posture into an activity of daily living. So these are the steps that we have to take if we want to achieve outcome in terms of therapy. And this is quite intensive as well initially, before the child can learn how to do it and how to maintain it. So, and subsequently they can do it at their home and a home-based program. So basically there will be, I won't be able to go into details because these are all these techniques you need to attend course, you need to be certified, and then only you can practice. So basically, the techniques which are derivative of the squats, they have a stable 3D postural correction. Then there will be an expansion technique, which they call axial expansion, also expansion in transverse. Muscle activation. So this is something like using muscle energy techniques. And then you have to gradually integrate all these three together so that self-correction can be maintained. So when this technique is used, basically what is done is initially it started in a gravity eliminated position so that the gravity is not. So you see a lot of mat-based programs, and then gradually you graduate as the patient learns and can stabilize the postural correction into with gravity postures and continue the therapy. So also what we need to do is we need to, for all the techniques, we need to classify the curve. So one has to be good at studying the curve, doing physical assessment, also doing should be good at evaluating the spinal X-rays. The X-rays has to be recent. The X-ray has to be AP. We also need to have a lateral X-ray because we need to look at the coronal balance when we are looking at how we are going to improve the posture and how we are planning the exact therapy approach. All right. So this is one way in Rigo's concept how they classify the curve. So the curve depends on what concept you're using. There may be some variation, but this is the concept. Basically, you classify the curve, and based on the curve classification, then you have to start a plan intervention in terms of keeping in aspect of 3D correction, stabilization, and using the muscle energy techniques. And sometimes you take assistance from certain accessories, as you're always seeing some bands and a wall bar, right? So it's not necessary, but I think it is initially important so that the patient can understand and facilitate and those specific areas of the curve, which is dovetailed with breathing, so that the corrective movement and sometimes the torsional aspect of the movement comes into action. So there's progression, how whether you use a mat, whether you use a sideline, and how we use other prompts to try and train the patient. Initially always will be in a gravity eliminated position, and subsequently the patient will start doing with gravity positions before, and then integration with the functional activities. Okay, so the other important aspects is also the bracing when we are thinking of conservative management of scoliosis. So what we look over here is the Boston brace, which has been, I think there is also Milwaukee brace, which I don't think Milwaukee brace is used at least in a lot of countries now, because I think the acceptance is very poor, and brace is only good if you are compliant. That means you need to wear a brace for almost 20 hours, so which is very difficult, especially in a like in Singapore, tropical climate. So it's not that easy, but definitely brace has proven to really make a big difference. So when we look at conservative management, we definitely have to look at brace as well, because sometimes brace and the exercise works hand in hand. Sometimes the exercise, how it is done, the brace is exactly designed to stabilize the corrective posture when the patient is not exercising. So we need to understand the bracing concept in quite depth. So what we are looking at is a Boston brace. Boston brace is an underarm brace which uses a 3-point pressure principles, which is a 2-dimensional brace. Basically, they have 2 deforming forces, 3 forces to straighten the curve, right? And what we're looking at, this is the Boston 3D braces, which incorporate the corrective movement, so that the concept of corrective movement is in the growth period. If the exercise and brace can be correctly applied, then there is growth modulation, so the curve does not progress. It's not so much why the curve does not progress is because we are trying to affect the growth pattern where the curve does not progress, and that's how we get stability, and that's how the conservative management is also measured in terms of the efficacy. So this is the Rigo Shenyu brace, which is normally based on how the Scots technique is there, and it is exactly based on that concept. So normally a lot of patients who are using scrot related techniques, they will graduate to this brace. But there are other braces in the market as well, right? So actually for the last almost like 10 years, I still do some, not that many. I was doing the spine crow brace. It do have a physio component, but it does not have a lot. Spine crow is also a corrective movement, and they have their own classification based on the AP and lateral view and the apex of the curve. So we need to identify and define the primary curve, and then we need to have a corrective movement. So when we do a corrective movement, we also do some surface marking, and then we do a trial brace. Then the patient goes and takes X-ray. We see how much of correction is, and then we correct the base. But the entire movement is held through this bands. So it's a high touch intervention. So the patient is to see the whoever is doing the brace every 3 months, and then we need to measure, reassess, and correct the tension of the. So we have been doing this, and we actually had quite good results at our hospital, and which we published as well. So there's a new brace which is developed in Australia. It's called Scoliosis brace, which is also a 3-dimensional brace, which is developed by a chiropractor who actually previously was doing spine crow. So this brace also looks like quite impressive. But a lot of new braces still yet to be published. I think for Boston, Rigo, and Spine Co, I think they are published results, which is available in SRS website. Yeah. So basically, if you look at what is the evidence of the scoliosis specific exercise, so it has been an integral part. I think SRS is one society that looks into the management of scoliosis, and also the surgical aspects. But SOSOR, so this is another group where they look into the conservative and rehabilitative management of scoliosis. So I think we look into the guidelines, which really tells the outcome of managing a child with scoliosis with curve-specific therapy and brace is definitely better. Brace, definitely there are numerous publications which shows that brace really helps in reducing the progression, so they don't reach the surgical limits for surgery. And if we can start intervening at the right time, looking at the patient's growth, there is significant improvement. And number one is we can contain the progression of the curve. Next two is, they may not necessarily need surgery, but the most important thing is the lesser we can keep the angle, I think there is lesser asymmetry, which has a big impact for these kids when they grow up in terms of their body image, how they bring them together in the society, and how they can be functional. So there are some publications which, in terms of the evidence that is there in terms of how physiotherapy can help in improving the outcome. But physiotherapy definitely means scoliosis therapy is not a corrective, but it works together to improve the overall outcome of in the management of patient with idiopathic scoliosis. So I think the other group of scoliosis that we have is those which are not idiopathic. So we have, this can be the different type of diagnosis that we can think of. where they do have a structural curve, can be CP, SMAs, Friedreich ataxia, DMD, myelodysplasia, traumatic brain. So these are the different type of other patients who will have also scoliosis, neuromuscular type. And for them, bracing can be sometimes helpful, but ultimately, most likely they have to go for surgeries. A lot of them are also managed in terms of positioning, whether we do modify their wheelchair or we modify their seat or we do their postural modification in terms of what all devices they uses. Physical therapy or physiotherapy can be helpful, but we will not be able to use the corrective techniques specifically in them because they have other etiology for the reason of having the scoliosis. I think that's the end of my slide. So I will stop sharing now. So basically, I would like to tell that when we are working with scoliosis, we need to work very closely. And at KK, I think we all run the clinics together. So since I have been working on the spine core brace and also now doing a bit of physio-specific exercise, which we do it. But some of the follow-up patients that we have, I also see. So basically, all the surgeons and the therapists and the orthotists, actually, we all run the clinic in the same clinic and side by side. So whenever there is a need, we can just pop into the other person's clinic, right? Fortunate, we have an EOS in our clinic. So all our kids, when they come, they first do their x-rays, then we measure the x-rays, and then we take decision on how we want to work. And all of us are also all the allied health staff are all privileged. So we can order x-rays, we can ask for x-rays if we need. So we work as a team with our orthosurgeons here.
Hi. Thank you, Dr. Sengupta. Before we begin the question answer session, I want to take a moment to thank Dr. Satyagi Sengupta for your elaborate session on assessment and the types of scoliosis and physiotherapeutic management, especially scoliotic specific exercises, bracing techniques. It was a very informative session for us. Thank you so much.
Thank you, Dr. Elizabeth, for moderating the session. And we are nearing to the end. So now I would request Dr. Urmila to take the question answer session. And I would request the participants, if in case they have any questions, they can put it in the chat box. And Dr. Satyaki, definitely thank you so much for a very, very elaborate thing. And it's your passion shows on it.
Yes.
So all of us, I really feel that it is a privilege to have you here. And really now talking of scoliosis, I believe it is such a thing that where we can really work, and how much physiotherapy, as Dr. Urmila mentioned, that we are into now functional therapy. So where all we can pitch in and coming as genomics medicine as a now stream, we can really take care of them very early if parents are aware, and if we are, whether it is a physiotherapist, whether it is their doctor, whomsoever they approach, if we really guide them, they can get the test done and they can look into it, whether the curve would be very aggressive or we can go gradual. And as you rightly put it, that when should be the bracing and when, as Dr. Ramani said, that surgery. So I believe we can really work a lot. And if the parents are educated well, so they can really take care of their children's fastnesses, which is a great effect. And over to you, Dr. Urmila. I believe it just came out of me so much. I wanted
that was such a great, that was really great. And thank you so much for Satyaki, Dr. Satyaki. I think you've opened the gates for a new therapy arena here, having a scoliotic clinic and working again as an integral part of this field, but working with cohesion. So that's an important keyword which we have learned from you. There's one question from the audience which says, does structural scoliotic curve also increase if we stop growing, that is after 20 years of age? I think this question, I believe Dr. Ramni had to leave for some urgent work. So
yeah, which I can answer.
yes.
So basically, so if we have a structural curve, which is, so if a curve is around 40, 45, then I think normally people will think in terms of a surgical correction. But curve which are below that, definitely which are in the 30s, will not be operated. So there is, even after the growth spur is over, the curve will progress. It's not that, but the progression is very not significant. There can be few degrees of progression over the decades. All right. So after 20 years, definitely there will be some progression. But unless there is any other symptoms, like, so a lot of adult scoliosis patients also have pain. Although I have, when I did my spine core is used a lot for pain management in adult scoliosis. I didn't do much because we are pediatric hospital, but initially we were doing some adult women's patient as well, because KK is a women's and children's hospital. So we were looking at some adult orthopedics. So we had some, so I was doing some, but then we can do bracing and things. And some of the Scroth technique also can be used for some postural correction, pain management. And so that's it, how one has to manage, unless it is, but it is quite different from the scoliosis we get at when elderly, elderly people also we get scoliosis. So that's quite different, and they behave differently. Yeah.
So one more question that comes to my mind is, yeah, that was very beautifully explained. Thank you so much. I think even Dr. Ramni sir gave us a very good idea about how should we watch the progression with age, with maturity, and how do we intervene in that. I had one question for you, Dr. Satyaki, is that, do you think that Scroth's method has an age lower limitation? Because what age would you think would be ideal to start? Can it be started in the very early age?
Okay, so since I have been working with kids for quite some time and doing a lot of, so I think the important thing is catching them at the right age.
Absolutely.
All right. So if we can catch the kids just when they are entering the growth spur, that means for a girl, so basically 2 years before their menarche, they have the highest skeletal growth. When I'm talking about idiopathic scoliosis.
That's right. That's
right. So if we can catch them at that phase, but if their curve is very little, then it's very hard to do things. But if they have a significant curve, maybe even below 20 degree, 15, 16 degree, I personally feel the role is there and it is preventative, because if we can, if I have a girl who will grow, who may not go for a surgery to correct the spine, but has a deformity, I would rather have the deformity as less as possible.
That's
because
right.
the aesthetics is better, right?
Absolutely.
Otherwise, how do you think that the girl will grow up as a teenager, as a young lady? I think, just to give a boost to her morale, for her self-esteem, we should try to keep it as much as less as possible. So I have been always telling them, you don't look at the corpse angle, you look at your aesthetics. You may not understand, but you need to do this, because this is especially important, because it's very hard to get the compliance of bracing. You have to wear it for 20 hours. It's really very tough. All right. But if we can keep the the deformity and the postural deformity and the coronal balance in terms of as less as possible, then they are not that asymmetric, right? So I think that is something which we need to think of, not only from the surgical aspect, whether they are going for surgery or not. Yeah.
Thank you so much for bringing out that esteem, self-esteem part. I think that really matters in these adolescent girls or anybody who has. So there's one more question from our audience today who talks of, for children with cerebral palsy, GMFCS 5 or 4, will bracing be the only option given we have a rigid rib cage? Also, what about the scoliosis due to any myopathies or older spinal muscle atrophy? So let's address one. So here we're talking of GMFCS 5 or 4. And do you think that bracing is the only option because it's a rigid case which is rightly put up? So I think we need to address her and talk of myopathies and spinal muscle atrophy somewhere.
Yeah. So if you look at cerebral palsy and where there is GMFCS 4-5, that means basically they are not ambulant by themselves, right? So the question is, at what Cobb's angle there will be, they will have respiratory issues, right? Right. So if normally with greater Cobb angle, you have restrictive disorders. So that's one consideration. So I think definitely these kids needs to go and do, like lung function or, but with these kids, if they're intellectually okay, then I think things much easier to work. If they are not, then it's not so easy to work. All right. And the other aspect is whether they have pain or not. All right. If they do have pain, then I think that needs to be intervened. So this all will tell us whether to go for a surgical correction or not. It is not that routinely done, but for some patients it is done as well. All right. So I won't say it is not done. They don't undergo scoliosis correction. For those which are neuromuscular condition, I think it is quite obvious. So if you look at the spine of neuromuscular, they don't behave like idiopathic scoliosis. So when especially the kids who are muscular Duchenne group, because the other SMAs, the progression is different. So the deformity and the progression is a bit different. But basically, if you look at DMDs, if they stop walking, they are still straight. They are in wheelchair, but they are still straight. So what we call is they are straight, but it is a collapsing spine. That means there isn't much support they get from the muscles to, so in a collapsing spine, the curvature suddenly comes and it progresses quite fast. And also we have to think that definitely they will have some, their respiratory functions at some point of time will be compromised. So when we are looking at neuromuscular patients, if they are stopped walking and then they also are being, normally they should be monitored by a respiratory physician, in terms of their ventilation, whether they are, they should go for a sleep study, whether they are, developing apnea or not. So the timing of the surgery has to be done where they are still safe for anesthesia. Otherwise, it will be another complication. So the timing has to be done appropriately. Means I don't think physios are much involved in the decision making, but when you see the, because other than scoliosis, I think the pediatric neuro is the other area I see clinically. So we see a lot of these patients as well. So the timing of the surgery has to be correct so that they are safe, because scoliosis surgery is a long surgery, 5 to 6 hours of surgery, and you immediately have to go to an ICU, right? So these are not small surgeries. So so they are quite big comorbidities as well. So it has to be done at time where it is safe to do the surgery as well. Yeah.
Thank you so much. I would just add a small comment here with your permission, is that we do need to watch when you're talking of bracing. You need to understand that we need to have the rib cage mobilization done because there's so much of crowding happening at the rib. Look at that vital, the lung and the breathing, and also look at the pelvis with the hips, because that asymmetry in GMFCS 4 and 5 is going to lead you to worsen up even if you do bracing. So if there is a hip, there is an asymmetrical pelvis, all these factors and a correction. And there's a certain different, one more aspect which we recently worked is a total motion releaser. So if you're, I don't have really the time to explain about it, but here we are looking at the symmetry, and here you really do a different kind of a release or a, a stretch technique in order to get that more expansion. People always tend to overlook that concave side and convex side. I think we need to understand that over the time, even that convex muscles start getting a little more stiff, and you really need to address them. So I think these 2-3 factors would help you in understanding this better. There's another question, Dr. Satyaki, which may be a little, is, just a minute, please. Yeah, so we have stopped that. The third question is, sorry. Yes. Is there any role of passive positioning using pillows in functional scoliosis cerebral palsy children, GMFCS 5?
I think if GMFCS 5 is very hard to tell whether they will have a functional scoliosis. All right. Yeah. So yeah. So if they're GMFCS 5 and then, but positioning definitely has a role for all these children who basically we term them as we call it long-term neurological condition, right? It's not only scoliosis. So positioning is very important for the neuromuscular patients as well, and also because they cannot move themselves. All right. So definitely positioning is a big topic, and it's a big area of work as well. So definitely it has a role, but if it is functional, it's very hard to tell because a GMFCS 5, whether how much of control the child has, so that has to be looked into, whether we can definitely position, but I don't think a pillow will be enough to position. So you might need to design something, a better support if you want to position. So I don't know, because since basically if we are looking at supporting a child in a wheelchair, then that is another area, basically how we make a wheelchair which will support the position. I think those who are working with children with who need specialized wheelchair will know that there are different options in sitting and positioning management, and that is a topic by itself. Yeah, so actually I was fortunate in KK to start the sitting and positioning clinic, which I think now has grown a lot. So we have it's in our hospital is still led by occupational therapists, but you have a lot of things. It depends on what type of chair, what type of insert, what type of material you use, and whether how you position the child. So definitely position has a role to play, but that will depend on whether we are trying to position the child in sitting or when lying down, and which I think will depend. But I don't think pillow will be enough support to position properly. Yeah.
Thank you, sir. Thank you, Doctor. Dr. Seema, you have to tell me, can I take questions?
Yeah,
it's a challenging topic, and
I can see the passion with Dr. Satyaki to be here with us till 11:15 plus or 11 at his end, and
okay, at 11.
Yes. So I'm really, really thankful. Maybe we can have the questions later. I would like to take a moment to thank all our attendees and the speakers, specifically Dr. Satyaki and Dr. Ramani, Dr. Urmila, and a moderator, Dr. Elizabeth, for giving your precious time and making this as a rich knowledge sharing experience for all of us. And I would also like to express my heartfelt gratitude to Dr. Anupam Sibal, the Group Medical Director of Apollo Hospitals, for envisioning, I would say, to provide us such a platform which could just break that glass ceiling and provide that, that communication from all ends, and then providing this superlative healthcare services. See what you do there specifically. Our audience are all with us over the time. I can really feel the amount of interest they also feel in this wonderful topic, which is less touched upon, and it is such a specific area. So I'm really thankful that we have a platform and we have people who are passionate like you, Urmila and Elizabeth, and all our attendees. So I would like to thank all the members of audience for being a part of this webinar and making it so lively that Dr. Urmila has to say, can we take more questions, because it is a little too late for Dr. Satyaki. Dr. Satyaki, I would say that people are so interested, they would not just mind, or they would not mind you to stay awake till midnight.
Maybe
Thanks
we'll
a
have one
million.
more follow-up session.
Yeah, we require that.
Follow-up.
So yes. So I would like to thank everybody who's here. And it is really, really amazing to have you all on board with us for this lecture series. And let's wait for the next one. So good night, everybody.
Thank you.
Thank you so much
everybody.
for
Thank you, Dr.
all
Thank
you to be here and sharing your rich experiences with us.
Thank you.
Thank you.
for
Thank you.
inviting me. Thanks.
So much.
It was a good learning for me as well.
Yeah, everybody. Thank you so much
Thank
for
you.
giving me this platform. Thank
All the audience also, I'm grateful for your time too. I believe definitely you would say it would be an enriching experience. Also, I would like to thank Gapio team, which is Dr. Sushil Jain, which is just the force behind the thing, that we all also participate along with Dr. Sibal's team, and Mr. Jitendra, who's still here with me from Gapio, to see that we really smoothly, just flawlessly make this happen. Thank you, everybody.
Thank
Wish
you.
a wonderful evening ahead, or good night.
Good night. Thank you so much.
Bye.
Thank you. Bye-bye.
Bye-bye.